speakers. Well, actually, it was only Liz before you. Well, Dr. Trish
She's
came
really
before you.
wonderful.
But she's wonderful. But Dr. Genisca is also a very good friend of Dr. Trish's. So, you know, we're doing this. But I think what we wanted to do is to show you guys that, you know, you can have your cake and eat it too. And everyone has their own ideas. In this group, we have many who have a rich global health background already. So maybe you get a conversation going. And I'm just personally delighted, you know, to introduce you, Alicia, to the group. And you'll tell your story, and hopefully they'll ask questions and, you know, be able to understand what led you to, you know, what you're doing now. It was sort of a little circuitous route, okay,
I like
as it usually is.
the way.
You know, and have them, you know, just drink in all the great things that you've done, and continue to do. I bow out from this, so I let you talk just with the students. And I do hope that our paths will cross. We'll stay in touch, of course. But if anyone is in going to Ethiopia, to Gondar, where the medical center is, ask her where that restaurant is. I hope it's still on. You know, I hope it's still open. Very good Ethiopian food.
Amazing.
Anyhow, ladies and gents, I give you Dr. Genisca, who will talk to you. And I hope everyone's well, safe, healthy, and sane. I'm signing off. Be well.
Bye, Dr. Finkel. Thank you so much. So hi, everyone. My name is Alicia Genisca, and I am Cornell class originally of 08. And then I decided to take a year off. And so I graduated in 2009. And that year I did a research year that Dr. Finkel was alluding to. I'm so excited to be here with you all today. I really, really love Cornell. As I was saying, some of my best friends are from there. My Olin bath roommate is one of my closest friends. Dr. Liz Trish is also one of my classmates that I have traveled to many different places with and worked and lived in many different places with. Dr. Ashita Batavia, who's also Cornell faculty, is a dear and close personal friend of mine as well. So I have so much love for the Cornell Medical School and so much love for this department because it was such a supportive environment. For someone who I had an idea that I was interested in global health, but what I could actually do with that, I didn't really know too much. And the love and support I got from Cornell was so fundamental in helping me on my path. So I hope that you guys I'm sure you guys are receiving that same support, but I'm happy to tell you a little bit of my story. So what I would like to do is I made some slides. They're all pictures, and I'm going to talk about my life. But please, at any point interrupt me, because otherwise it's just me talking, and I'm not about that life. So I would super appreciate if at any point, if you just wanted to interject, ask a question, feel free. The other thing I was going to ask, if possible, if you feel comfortable, is just showing your faces. Maybe not right now, because I'm going to show the PowerPoint presentation, but towards the end, as we get to discuss a little bit more, I would love to see your faces if you feel comfortable, just because I'm so excited to see, you know, the new life that is at Cornell, the new life of global health at Cornell. It's really wonderful and exciting. All right, well, that being said, I'm going to share my screen. Bear with me for just a moment. I've actually been on Zoom for several hours today, at least 5.5 hours so far, so I should be very expert at this. Okay. All right. And again, as I said, please feel free to interrupt at any point in time, just to ask questions. I would love for this to be more of a discussion. So, Global Health Career Seminar, this is my talk about my life. So we start off as a tale of two countries. Who can identify these flags?
Jamaica and Haiti.
Woohoo! Yes. All right. So that's where my family is from. My mother's Jamaican, my father is Haitian. And this, I think, is really where my global health life started. Um, I spent a lot of time in Jamaica when I was a little kid. Actually, just growing up, we were probably there at least once a year. Haiti, sadly, I only made it to once in my lifetime as a small child. So that's me with my Haitian grandmother a long, long time ago. Um, I bring this up because I feel that my background has really helped me to move into global health and to move in global health in a way that I may not have without this history. When I was younger, there was a period of time where we did live in Jamaica. Um, Mosquitoes love me and completely would bite up my skin. And at one point, you know, they're itchy, they're awful. I was scratching, I was digging, I was, I don't know, 7 years old. And I got a really, really horrible soft tissue infection, a really bad cellulitis, and ended up having to go to the hospital in Jamaica. We first went to a private clinic and then ended up at the public hospital just because it seemed like the private clinic was a little bit shady, but that was just one particular place. But even at that young age, I was very much able to see how different this was to my pediatric primary care clinic in Boston, Massachusetts. Going to a hospital in Jamaica, it was completely different than anything I had ever seen before. And so that always stuck with me in the back of my mind as I went throughout my career. And another thing is when I was younger, somehow, some way, someone put it in my mind that I was going to be a physician. So I was already starting to think about why is this hospital different than what my hospital in Boston, Massachusetts looks like. So this is where my starting point is. So between being a small child in Jamaica and heading off to university, as I mentioned, I knew that I wanted to be a physician. I was very excited about it and, you know, just trying to make the next steps. What do I have to do? Okay, I've got to get out of elementary school, got to get out of middle school, got to get out of high school, and then finally go to college. So I ended up at Johns Hopkins University for my undergraduate. And at the time when I started, I wasn't very certain what I wanted to study. I started off as a biology major because that's what everybody did at Hopkins at the time. And thankfully, around my second year, my sophomore year, Hopkins had created a public health undergraduate major. So you could graduate with a bachelor's in public health. And I decided to switch into the bachelor's of public health. The reason being, I was very interested again in the world of global health, but I didn't really know too much about it. I just knew global health was a concept. People went to different countries, got to help improve healthcare systems, but I didn't really get to learn too much about it until I was finally in the concentration for it. And one of the first trips or rotations that I'd ever done was to go to Navrongo, Ghana, which is in the northern part of the country. And this was between my junior and senior year of college. And it was an eye-opening experience for me. Before that, I'd only had my one-time experience in Jamaica. And now I'm going off to Ghana to learn more about global health and see how healthcare is practiced in other places. For the 6 weeks that I was there, I I worked at a health research center, basically helping to weigh little children and take blood samples for a malaria study. And then I also had the opportunity to work with a physician at the regional hospital. Now it's a regional hospital, so it has a ton of patients that come in. And there were supposed to be about 5 or 6 doctors working there at the time. But there was only one person who showed up consistently, one physician who showed up consistently. And he would go and do rounds on the pediatric wards, the nursery, the male ward, the OBGYN ward, and the surgery ward, see all the patients in the hospital essentially. And just with his hands, no labs, no imaging, just with his hands, would be able to diagnose and provide pretty great care for those patients there. I was completely impressed by this ability. I had never, the world before me, or what I knew about that, what I knew about medicine before that was that, oh, you get your lab tests, you get your, your imaging, everything is at your fingertips. But here is a person who simply by using his hands and his stethoscope was able to take care of most medical illnesses for his patients. And so that was a big, an important experience for me. That summer also allowed me to go to Havana, Cuba. Hopkins at the time had a small, not exchange program, but a small summer study program where you could go to Cuba for a month and learn about the public health system. And since I was a public health major, this absolutely made sense. I was able to spend 3 weeks in Havana, going around to see the different types of clinics that were available in the Cuban healthcare system. I was also able to go to centers for physical therapy, to operating rooms, to skilled nursing facilities. And I mean, I think anyone who studies public health cannot complain about the quality of care that is provided for folks in Cuba. You have a primary care physician. Usually your primary care physician lives and works in your neighborhood, so you do have easy access to them, and everything is free. Not saying that that's the perfect system. We all know that there are pluses and minuses to any healthcare system, but it was working pretty great. And it was a wonderful experience for me to be able to go and see this system. Then we got to spend 1 week in Matanzas, which is where they have a large medical school, and spend time with medical students there, which was really excellent. So after graduating from college, I took a year off and I worked at the Children's National Medical Center just as a researcher in the emergency department there. At the time I was applying to medical school, and I hoped and I hoped and I hoped and I hoped that I would get into Cornell, and I was so glad that I did. One of the things that impressed me the most about Cornell was the opportunity for medical students to be able to do these clinical rotations abroad with not only mentorship support, but also some financial support to get students to these countries. So that was really excellent, and why I was so excited. One of many reasons I was so excited to go to Cornell. So in the summer between my first and second year of med school, I went with my classmate, Emily, here in this picture. We went to Santo Domingo, Dominican Republic, and spent the summer there working at this clinic called Pro Familia. And here I am with some of the Pro Familia staff. Pro Familia was basically a clinic that really focused on family planning. So as a medical student, I got to scrub in on some cases of vasectomies, tubal ligations, also participated in helping women do some of their family planning, deciding what sort of contraceptive methods they would like to use. So that was a great experience, and I was thankful to Cornell for allowing me to be able to do that. And then during my fourth year, I was able to do the 1-month clinical rotation at the American Hospital in Paris. And I highlight Ashita Batavia here because she was my classmate, and she was also the person that I went and did my rotation with. During that 1 month, we were able to see what the healthcare system looks like in France, which is very different. A lot of times when people think about global health, we think about being in low resource settings, but here we are going to definitely not a low resource setting, and seeing how healthcare works in one country in Europe. It was a really wonderful and interesting experience to see how socialized medicine can work. So really appreciated my time there. And again, that was through Cornell. Also during my time at Cornell, I applied to be a medical student to do a clinical rotation. I know that Dr. Trish talked with you guys last time about Baylor and their, it used to be called the International Pediatric AIDS Initiative. It's now gone on to be called the Global Health Corps. But basically Baylor, probably I think it's about 15, 20 years ago now, seeing the high burden of pediatric HIV in sub-Saharan Africa, partnered with different ministries of health to create these clinical centers of excellence to provide outpatient care for pediatric HIV positive patients. So as a medical student, I was actually able to go to Botswana and helped to see patients in the clinic in Gaborone, Botswana, which was a wonderful experience. Not only because I had this time on the ground, but that actually helped me to start thinking about what my career could look like later, because I was working with people who were pediatricians from all around the world who had come to work at this clinical center of excellence. So I finally got to see what a career in global health could look like on a day-to-day basis. So after graduating from Cornell, I matched for a pediatrics residency at the Children's Hospital of Philadelphia. And I was excited about being at CHOP, mostly, for multiple reasons to be excited to go to CHOP, but they also were very well known for their global health work. And so while I was a resident at CHOP, I did get to do some clinical rotations. I got to go back to the Dominican Republic, but this time was in Consuelo, Dominican Republic, which is a little bit more rural. What I enjoyed about this experience is that on this top left corner here, you're actually looking at areas of that used to be sugarcane fields. These are called batés. Dominican Republic and Haiti have a very interested and sordid history. If you ever want to read a great book about it, there's one that's called Why the Cocks Fight, but it talks about the relationship between Haiti and the Dominican Republic. But basically, at one point in time, you had a lot of Haitian migrants coming over into the Dominican Republic to work on the sugarcane fields. And those people stayed for generations and generations. So their children were born there. They spoke Spanish only, and were considered Dominican citizens until recently, unfortunately. But these batés still exist where you have people living in areas that may not have the most of resources, and actually folks getting healthcare there, it can be quite a challenge. And so when I went down to the Dominican Republic the second time around, I was helping to do health outreach to these communities. And that involved bringing in, doing deworming and vitamin A supplementation for children who are less than 5 years of age. And then also there's a very strong network of community health workers in this area, again, because it's hard for doctors, nurses to get in there. So they have a whole brigade of community health workers who go in. And I got to talk with the community health workers about breastfeeding and breastfeeding practices. The longer you're in global health, the more you learn about different myths and beliefs about so many different things. And in the Dominican Republic, there were a lot of interesting myths and beliefs about breastfeeding. So I gave a little talk to our healthcare promoters about breastfeeding myths, and then they then went on to use that to talk to women in these communities. And these are just some of the patients who are lining up here waiting to be seen in clinic. I put this picture in intentionally because in the US, when we come into any sort of emergency service, it's not first come, first serve, but in a lot of other areas, it's absolutely first come, first serve. I got here at 5 o'clock, I was the first person in line, I'm the first to be seen. That does not work well if you are patient number 7 and you're really sick and you're just sitting and waiting your turn. And I bring that up now because I'm going to talk about it again later because it informed some of the work that I do now. So during my residency, having had the experience in Botswana with Baylor's Global Health Corps, as a third-year resident, pediatrics resident, I went back to another Baylor site, this time to Eswatini, formerly known as Swaziland, which is a small landlocked country within South Africa. They have a king. It's a beautiful mountainous area, and I again worked at their HIV clinic. One of the things that was interesting that's happening at this time, so as a third-year resident, I'm thinking about jobs, what am I going to do, where am I going to work? And I had been so excited and moved by all the different global health experiences that I had that I really thought about it and said, you know, I could do MSF, Doctors Without Borders, but I'm really interested in doing I think I want to be a Baylor Global Health Corps doctor. And so while in Eswatini taking care of patients, I signed off saying, yes, I'm going to be one of your physicians until you kick me out. And so that's how that was the next natural step for me in the progression of my global health career. So as a Baylor Global Health Corps doctor, that my first assignment led me to Gondar, Ethiopia, which is the third largest city in Ethiopia. There's Dr. Trish and I think on our first day of arriving to our new town, went out to get some food. The next picture is just showing Ethiopia the way that I will always remember it. I think for many of us who may not have traveled before, or just people have certain thoughts in their mind when they think of Ethiopia. They think of famine, they think of drought, they think of it being destitute. And Ethiopia, especially during the rainy season, is one of the greenest and most lush places I'd ever been. And actually their new year is September 11th, just at the time that the flowers are starting to bloom. But it is one of the most lush places I've ever been to. As Dr. Trish had probably mentioned to you before, Baylor's role in Ethiopia was to try to create a pediatrics residency program. There was a huge brain drain, and in fact, there are more Ethiopian physicians working outside of Ethiopia than in Ethiopia. And this program was really to create new pediatricians in country. And so over the next year and a half, my roles included teaching pediatric residents as well as medical students. And that's a picture of me testing medical students. In addition to my administrative and educational roles, I also had a clinical role as well. Part of the clinical work that we did was taking care of patients on the inpatient service. Inpatient included general pediatrics. We had a nursery, a NICU, and a malnutrition unit as well. And just as we were leaving in about 2014 is when they started to have a pediatric intensive care unit. But we were responsible for those patients as the attending physicians. Here, just a couple more pictures of Ethiopia to give you a sense of what our hospitals look like. So this picture on the top left is actually sort of a combo maternity / nursery, maternity ward / nursery. So mothers would come in, have their babies, and if their babies did not require intensive care, they would be placed in this unit. And as you can see, even though this is the third largest hospital, or third largest city in the country, and this is the big hospital for the area, there's a lot of overcrowding that can happen. The next picture just shows one of our pediatric residents sitting in the outpatient clinic waiting for patients to come along. Here's a picture of us, of the inpatient pediatric wards, and then a picture of the neonatal unit. So if you guys look closely enough, you'll see a bottle with not a hose, but with some tubing. Does anyone know what that is? Anybody?
Maybe like for warming the babies?
So not for warming. So underneath there's actually a little radiator for warming the babies, but that's a good thought though. Has anyone heard of bubble CPAP or CPAP at all? Sorry, I can't see your faces. So if someone yells out yes.
I've only heard of CPAP in the context of sleep apnea, so I'm not sure if that's related.
Yes, it is. Absolutely. It's totally related. It's the same mechanism. So CPAP is basically a device that generates pressure to keep your airways open. And so for NICU babies, for babies who are preterm and just came out too early, they don't have enough surfactant in their lungs to keep their smaller airways open so that you can have very good gas exchange. And so CPAP is a way to distend those lower airways to keep that open. Now, when we think about that in the US, as you mentioned, CPAP for sleep apnea, that is one indication for that for CPAP, but it's also used for respiratory distress and for patients who need to keep their airways open. So for a newborn or preterm baby who doesn't have their airways completely popped open, this would be the mechanism we would use for it. In the US, again, we're used to these big fancy machines with like a nice head wrap that you can put around. My dad uses a CPAP. He's got like a little headgear that he uses with it. And there's a nice contained machine that he uses. That is not available in Ethiopia, but what we do have is what's called bubble CPAP. I won't get into too much detail about it, but basically you take a bottle of water, any sort of bottle of water, you measure out, 5 centimeters, 6 centimeters, and you put in the tubing at that depth, and that generates pressure. You hook it up to oxygen, and that generates pressure. So you can make your own CPAP in order to help these neonatal patients. So in a lot of places, even though they're considered low resources, you can do a lot with just a bottle and some tubing and some oxygen to help these babies survive. So that little thing right there is just a bubble CPAP for that patient. And I also just wanted to show you, have you guys notice again, we've got 3 babies to one bed, just because that's the availability of the resources that were there. So at the end of our time, so we succeeded. The goal is, anytime you're doing something in global health, is either to replace yourself or to leave something that is sustainable. And as I mentioned, this was a program to create pediatric residents and pediatric faculty. And so we were able to graduate the first class of pediatric residents in Gondar, not in all of Ethiopia, but in Gondar. And so that was great. We were at a job and it was time to move on. And so my next step was to continue on with Baylor Global Health Corps and go to Rio Hacha, Colombia. So this was the first program that Baylor had ever done in South America, the first program they had in Colombia. And the purpose of this program was specifically targeted to the Wayuu indigenous people. The Wayuu are a semi-nomadic indigenous people who go back and forth without borders between Colombia and Venezuela. And they tend to live in what are called rancherias. And if you look at the bottom left, this is a typical rancheria. Rancherias are extremely, extremely arid. It's very hard to find water there, and it's very hard to grow anything there. And so most people subsist on chicha, which is corn. And so breakfast, lunch, dinner, there's some sort of chicha involved. In these communities, what the Colombian Ministry of Health was finding is that there was an incredibly high rate of malnutrition and deaths from malnutrition for children under 5, and also for pregnant women. So Baylor's program was specifically targeting this group of indigenous folks, the Wayuu, to help improve their nutrition. What's also interesting about the Wayuu is that their form of currency is chivo is having a brain. Chivo is a goat. Sorry. I can see it in my mind and not remember what it is. So a lot of these families had a ton of goats, a ton of cows, but that's their currency. So they are not going to use that to eat, although that would be a great source of protein for them. So it was interesting to see so much malnutrition where you have tons of cows and goats walking around. So the picture on top of that rancheria is a mother with her kids. And one of the things that I wanted to point out to you is, see how this young lady's hair is a little bit blonde? Does anyone have any thoughts as to why that happens? It's not just highlights.
Kwashiorkor?
So not quite Kwashiorkor. You can see this in Kwashiorkor or marasmus. So this is what's called kind of the flag sign, where you have, so this is someone who you would expect to have phenotypically dark hair, and then you see lightening of her hair. The light part of her hair is representing those times when she doesn't have enough enough nutrition. So her hair is much lighter during that point. And you can see for her big sister here, you're seeing a little bit of that as well. This is just another one of the patients that I took care of in the clinic. He was about 3 years old, and this is definitely not the size of a 3-year-old patient. And this is another one of my patients. So basically in Rio Hacha, what I was doing is seeing patients in clinic, and also going out into these rancherias to evaluate patients there. If there were patients that were concerning for severe malnutrition, we would refer them into the main hospital. But oftentimes families could not get there. I still remember a mother coming in to clinic, and I diagnosed her child with severe acute malnutrition, and I was explaining to her that we would need to transport her son to the hospital. And I had definitely had times of resistance where families were like, no, he's fine, don't worry about it. My other kid looked like this, he's going to be fine too. But this mother was nervous and did not want to leave because she had come to clinic on her donkey, and it was an hour and a half away. And now we were asking her to get into an ambulance to go into the city. And her concern was, of course, I want to take my child in, but what do I do with this donkey? Did not have a good answer for her at that point. But so I saw a lot of patients in these clinics, mostly seeing children who were malnourished. And so out of that grew a program that's called SAIL, which is Salud y Autosuficiencia Indígena en La Guajira. Basically, this was we started a nutrition program to help nourish children who are less than 5 years of age, and also pregnant women. Again, because as I was highlighting before, there is a lot of malnutrition in these two particular groups. So these are, this is me with my healthcare promoters. We had promotoras de salud that I got to teach them about malnutrition, as well as concerning danger signs for pediatric patients when they should refer somebody in from the community into the main hospital. This is one of my promotoras checking the mid-upper arm circumference for a mother to see if she's malnourished or not. In addition to my clinical activities, I was also tapped to do a lot of educational activities, which was very exciting for me. These educational activities included giving talks to folks from the Ministry of Health, to health promoters, to different nurses, and there'd be a wide range of topics from malnutrition, how to treat malnutrition appropriately. I even began teaching at one of the local hospitals. They had a lot of, so in Colombia, it's a 6-year medical school program. You go straight from high school into 6 years, like most other places. And in your final year, you do an año rural, where you are placed in a rural area of the country to work. And what I would do is basically on Fridays, I would have educational lectures for those medical students in their final year. And this was one of these formative moments for me as well, mostly because in a lot of places, remember, they may not have particular subspecialties. So pediatrics is considered a subspecialty. In fact, in Colombia, if you want to become a pediatrician, the medical school part is free. Great, wonderful. But if you want to specialize in pediatrics, you have to pay money to do peds. You have to pay money to become a surgeon. You have to pay money to do any other sort of subspecialty or specialty. So many people are general physicians. And for a lot of those folks, having a sick kid come in, it's very nerve-wracking, it's very terrifying. So this almost year helped me to refine my teaching skills. And it was something that I got very excited about, being able to teach people that children are not small adults, we all know this, but also children are not scary. Yes, there can be a very sick kid, but here are the certain steps that you need to take in order to be able to take great care of that child. So that was a spark of passion for me in terms of teaching. And in addition to my clinical activities, my educational activities, I had advocacy as well. This was a new program, and we were addressing what honestly people were calling Colombia's dirty little secret, because nobody really talked about the malnutrition that was happening in these communities. In fact, while I was there were a lot of exposés on TV talking about malnutrition. And so because of that, I actually got to go to La Casa Rosada, which is the White House, and or the White House of Colombia. And I got to meet the First Lady of Colombia to talk to her about her program to gain support to help increase our reach, which was really wonderful. I've had advocacy training and residency as well. I've gone to the gone all the way down to DC to talk to senators, but I've never met a First Lady until this time, which was really wonderful. So while living in Rio Hacha, Colombia, as I mentioned, that spark had sort of happened where I knew that I was very interested in teaching more, especially because, again, I don't think pediatric patients are to be feared. And at a conference by the Colombian Pediatric Society, their annual conference, I met some other physicians from Baylor, from Texas Children's Hospital, who technically I worked for, but I had never met these folks. And I met a lovely physician by the name of Dr. Andrea Cruz, who is board certified in pediatric emergency medicine, as well as pediatric infectious disease. And at the time I had been thinking about moving back to the United States, but not really certain how I would continue to mesh global health. The only other folks that I had seen do global health in the way I loved it were living abroad. But if you're in the United States, what I was seeing was a lot of people just saying, well, I took my 2 weeks of vacation to go and work on this project. I really like my vacations. They are for me. So that's my time to recuperate and refresh. So that model was not going to work for me. So in speaking to Andrea Cruz, she said, well, why don't you consider pediatric emergency medicine? And I said, well, that means that I would have to do a fellowship. I've been attending for almost 3 years now. Why would I go back and do fellowship and incur more debt? And, I finally paid off my credit card. Why would I do this? And she said, well, in peds emergency medicine, because you have shift work, you can move your shifts to other areas so that you can get a week off or 2 weeks to go and do whatever you need to do. And that doesn't count against your vacation time. And I said, okay, well, yeah, but then I'd have to do fellowship. That's another 3 years of my life. I'm already older. I took a year off during med school. This is, not really what I'm excited to do. And I took a year off before starting med school as well. So it was like, I don't really feel like this is going to be the right move for me. But that little tiny voice kept going in my head. And, at some point I realized, I said, Alicia, you have actually been teaching emergency medicine for the last little bit in Colombia, because you're teaching all of these pediatric these medical students and some other physicians about how to deal with malnutrition emergencies, seizures, diabetic ketoacidosis, asthma crises. And you were doing that in Ethiopia as well. Part of my bedside teaching was teaching how you deal with an emergency, so that if you are the intern there in the middle of the night and your attending doesn't pick up their phone because they're in a really heavy sleep, what do you do? So I'd actually been teaching emergency medicine for the last, almost 2 years. And so at that point I said, well, maybe it's not a terrible idea to do this pediatric emergency medicine fellowship. And it absolutely turned out to be the right thing for me. So I applied for PEM fellowship, and I matched at Baylor Texas Children's, which I was super excited about since I'd already had this long-standing relationship with them. And Baylor Texas Children's actually has its own pediatric emergency medicine fellowship plus an additional year for global health. I did not want to do that because I didn't think an additional year was going to add anything new that I hadn't learned in the last almost 3 years of being out. And it was a wonderful, wonderful opportunity for me. So probably about a few months into me starting at Baylor as a fellow, it turns out that there was a new faculty person on the adult emergency medicine side who had been working in Belize for decades. And the main hospital in Belize, Carl Huchner Memorial Hospital, felt like they were not doing a great job of taking care of their pediatric patients in the accident and emergency department. So they wanted to have people come and teach them about pediatric emergency medicine. Hello, great, that's awesome, I'm there. So during my fellowship, this is what my fellowship project actually became, was improving pediatric emergency care in Belize. And so there were sort of two main projects that we worked on, which one was a triage for pediatric patients. The World Health Organization has a fabulous pediatric triage tool. Within 90 seconds, without using any equipment, you should be able to look at a pediatric patient and decide, number one, do they need to go to the critical care or be seen immediately? Number two, are they a priority patient, meaning that they could wait a little bit, but there's somebody that needs to be seen soon? Or number three, can they sit and wait in the queue? And that is going to bring me back to that picture in the Dominican Republic that I was talking about. Remember all those folks who were lined up waiting to be seen? Again, in the situation where you have a good triage system, that patient number 7 who's really sick is going to jump to the head of the line. And so that's what we were teaching, starting to teach in Belize. In addition to that, we actually created a 6-module pediatric emergency medicine curriculum for non-specialist providers, with the idea that anybody who sees a pediatric patient in the accident and emergency department would be able to take care of them. And so both of those programs we started back in 2016. Initially, it was myself and my colleagues going down to Belize to teach the first couple of sets of Belizean colleagues. And since then, we've actually trained our Belizean colleagues in the triage model, and they have gone on to continue to teach pediatric triage to their colleagues. And we've trained over several hundreds of people for pediatric triage, which has been really wonderful. So that now leads me into faculty life. So in 2018, I took a position here at Brown as part of the Pediatric Emergency Medicine Division, as well as the Division of Global Emergency Medicine. And so what does my global medicine faculty life look like? Lots of different things. So a lot of different doors have opened up for me since being here, but I still continue to work on projects that I've done before. So I started in September of 2018. In October of 2018, a friend of a friend said, hey, they're going to be doing this new World Health Organization training session called Basic Emergency Care. We know you have experience in Ethiopia. Would you mind coming and teaching the course? I said, sure. I've never seen this course before, but if it's anything like our pediatric triage, which it really was, it should be a great course to teach. So within a month, or actually 6 weeks of me starting my faculty life, I was on a plane to Ethiopia, spending a week there, teaching basic emergency care. That then opened up more doors for me because now I'm a master trainer of basic emergency care. Let me stop for a second to tell you what basic emergency care is. So basic emergency care is a training that anyone can take. And the purpose of it is, if there's an emergency anywhere, you as a community health worker, as a physician, as a nurse, should be able to manage emergencies. So let's say there's a car accident, you want to make sure that the patient's C-spine is intact so they don't end up with paralysis. If this is a patient who might have some sort of crush injury, how to take care of that crush injury to the chest. If you're worried that the patient has a tension pneumothorax, you're going to place a needle, how to place that needle, all of these different things. And so this program started back in 2015, I believe, and the first studies coming out of it are showing pretty good data for it being able to, not only do people like the course and feel more confident managing emergencies afterwards, but they've shown some decrease in mortality as well. So after having taught this basic emergency care course in Ethiopia, I was then able to bring that to my colleagues in Belize. And our goal is to train at least 80% of the healthcare providers in Belize on how to do basic emergency care. And to date, we have been able to train 40%, which is really great. In addition to my basic emergency care coursework, I have been involved in a lot of different projects, including so I've been volunteer faculty for the Harvard Humanitarian Institute. Each year they run a humanitarian response intensive course. And at the end of this 1 month long course that students take, there's a 3-day simulation in which these students are taken into the woods, and it's all dressed up as if it were a low resource country on the brink of civil war. And they have to go through different simulations over the 3 days. And so for the last 2 years now, I've been faculty there, acting as the water and sanitation specialist, which has been a really wonderful experience. One of the things that I had mentioned, or I don't know if any of you caught me talking to Dr. Finkel about this earlier, is I said I'm really not a researcher. I love clinical work and I love education and making healthcare providers feel confident and comfortable taking care of pediatric patients. But that doesn't mean I don't do any research. In the last year, I've actually been working on creating a predictive diagnostic and a prognostic tool for Ebola virus disease in pediatric patients. So hopefully at the end of the study, we'll be able to say who are the pediatric patients who are most likely to get Ebola and most likely to die from Ebola, so that we can allocate resources appropriately. Also, during my time here, I have been involved in some community advocacy work, most recently talking to families in Providence about going back to schools, because the schools have reopened here, but particularly in our Hispanic community. So I've served on a panel talking with families in Spanish about how to safely be able to send their children back to school. And even though we are in a pandemic, I'm still getting to do a lot of global health work. Most recently, I've been working, or my entire division has been working with Project Hope, which is an NGO that serves multiple different places in the world. And we created a COVID-19 course to help educate other healthcare providers about what COVID-19 is, how do you test for it, what are the signs and symptoms, what is the management, how do you communicate to large populations about their risk for COVID-19. And so I've been working with my division on that since April of this year. And very excitingly, basic emergency care is going virtual since we're not able to go to many of the countries that we had planned to roll this out in. So we are going to be doing a basic emergency care virtual course next week, which is pretty exciting. All right, that is all I have to say. And I feel so terrible because I feel like I've droned on and on, but please feel free to ask any questions about anything that I've said. And if you can I see your
Thank you so much for that. Yeah, I do have a question for you.
Yes.
Thank you for sharing that entire journey. Like, clearly you've been everywhere.
It was really long. I'm sorry. I just realized the time. I was like, oh my gosh.
No, it was really awesome. It was great to hear like all the different places you went. And my question is based off of that. Like, it seemed clear, and you talked about it, that it was like cool to be able to transfer teachings from one site to another, even though they're completely different contexts. But I was just wondering if you could talk a little bit more about what goes through your head in terms of the merits of like being in one place for a longer time and like having a better sense of the context and the culture and sort of the way systems work, and be able to do advocacy work that way, versus sort of having a sense of a lot of different sites and countries and people.
Yes, absolutely. I think that's a great question. So, I don't think there's any wrong, well, there are wrong ways to do global health. Sorry, that's not true. There are wrong ways to do global health. Going in and saying, this is what we're doing and not talking to people about what they want is the wrong way to do global health. But in terms of time spent on the ground in each individual place, it depends on what the goal is for the country that you're working in, and also what your goals are. So, I think when you are a medical student, when you're undergraduate, you may not have many skills to offer. So you're not going to be the person who's running, the ICU or the COVID-19 unit or anything like that. And then that's when you might be doing smaller stints. But as you have more clinical understanding under your belt or different skills, for example, having a master's in public health and being able to do research really well, if you have a different skill set, you can definitely stay longer. For me, my smaller times were all while I was a trainee, which I think was appropriate because most training programs are not going to allow you to spend more than 4 to 6 weeks outside of the country anyway. But as an attending, going back, that was a personal choice for me. I had known all along what it felt like to have a little snippet of being in a different place, but then actually being firmly rooted and having a community and friends and a work life and all of that felt very different than, 4 weeks in Dominican Republic or anywhere else. So, and to be honest with you, I think it makes it harder to leave sometimes, and it makes it harder to not continue to be involved. So for example, I have loved every country that I have worked in, but I have never ugly cried more than when I was leaving Colombia, because I saw in a short period of time, kids going from near death to being happy, playful, running around. I mean, there are families that I just still remember their faces. And I also knew that I had meant something to the community. Remember, I mentioned before, for a lot of the YU, money is a goat or a cow. And on one of my last days, my health promoter, she served goat, like she basically cooked a goat for me. And that was so meaningful. I wouldn't have gotten that in a 4-week snippet of time. So I think if you have the purpose of being somewhere long term and really getting a better sense of how you can turn things around, or different projects are just going to take time, you need to be there longer. But if you're going for small snippets of time, I don't think that's a time to try to mount a massive program or anything like that. I mean, but either one of them works. For some people, they just want to get a brief sense of what it's like to live to work in an under-resourced setting. And some people want to live and work in that under-resourced setting. So it's, the work plus the lights going out, the internet not working, maybe the water's not working either, or something like that. Or, for me in Colombia, a lot of it was security issues, making sure that I was with a driver at all times. I couldn't even walk a block without having a driver. So there's many different things that you would exchange for that. But I don't think that one is necessarily better than the other. I think they're both great experiences.
Thank you.
You're welcome. Sorry, guys. You guys have heard me talking for a long time now.
I have one question.
Yes.
So knowing that each country has a different healthcare system, how did you approach preparing for each of your global health trips, knowing that there are cultural factors that play into how people perceive and receive healthcare?
Sure,
what was that process of getting ready to do healthcare in Colombia, in the DR, in Haiti? What was that process like for you?
So it's, I tend to ask the people who have already been there what's going on. Maybe for Dominican Republic and for, for France, I wasn't worried about. I'd gone to France as a student, and it was just about making sure that I was respectful of everybody that I came in contact with. But for Dominican Republic, it was talking to other students who had either been there or with faculty members who had done work there previously. And then for my bigger moves like Colombia, Ethiopia, we talked, Colombia was different, but for Ethiopia, we talked to the former Baylor doctors who had already lived there. So we already knew who was who not to look side-eyed at, who, where to get certain things from. Colombia was a whole new world. And so though I did a lot of reading beforehand, I was talking to the folks who had set up the project beforehand, so they could walk me through what their expectations were. They told me who all the key players were. Lots of documents before going into Ministry of Health meetings. Like, I had to be on it because I'm not Colombian, and I'm an American walking into the situation, and it was important. So I got a lot of that information beforehand from colleagues. And I think that's one of the best ways to prepare, is to talk to people who've been there before, who might be going to your exact same setup.
Thank you so much.
Oh, you're welcome. Oh, I recognize Lasden. Or is that Lasden?
Yeah, we're in Lasden.
What floor are you on?
6.
Oh, okay.
Yeah, what floor did you live on?
I lived on the 4th floor, and then where did I live when I came back? 9th, 4 and 9.
Oh, so now how it's designed now, the first 5 floors are like office buildings.
Oh,
so we're the first residential floor.
Oh, okay. I have no
Yeah.
home anymore when I come back. What other questions do you guys have?
Hi, thank you again. It was good to meet, and I agree. It was such a good like time like listening to all your experiences. Um, and I was just thinking because I'm also from Haiti, by the way, so I was so excited. um, and I relate to your story a lot in terms of like for me, like this is kind of like where my love for global health is kind of like rooted. I was born and
Mhm.
raised there, so it's kind of like I feel like it's always gonna be in me.
Yeah.
But I'm a fourth year and I'm applying to orthopedics this year, and
Mhm.
it's kind of like it's different for surgical fields in terms of like in terms of like any surgical field, including orthopedics and how that relates to global health. I know
Mhm.
you're in peds and I know you did emergency, but like have you come into contact with or any like thoughts of how people out there have like maybe incorporated or merged any surgical specialties or like for me when I look into the future I'm like how am I going to merge orthopedics and global health in my career. So
Good.
just wanted to like see if you had any thoughts or any like encounters with people like that. Yeah.
Yes, of course. So my two thoughts are there's kind of two camps that you can go for. So one are the shorter, small trips where you already have set up in advance. There's a predefined population that you've read all their charts and you're going to go in and you're going to do your orthopedic thing for a week or 2 weeks. You're going down with a full team of, anesthesiologists and your ortho team. So that's one way of doing it. Another way is educational opportunities. That is one of those sustainable things that I love. This is like the thing that I eat up the most is the sustainability of being able to go in and say, okay, what are the, maybe starting small with some small orthopedic procedures and saying, what can I teach to this group today? Or what are they interested in learning? What, for the folks who are there already, what are they interested in learning? Can I go down and start to teach that? Can I have a mentorship relationship through Zoom, through WhatsApp, through Skype, where I can continue to do lectures online, even if I'm not in country,
Yeah.
and then eventually get to be down there so I can be in the OR with folks. So I think that's the
Yeah.
two ways that you can do it. Now, I don't have a specific friend in mind when I'm like, well, who's
No,
going
but
down
that's
to
been
do
very helpful.
but I'm actually thinking of Eva Asamoah, who was one of my med school classmates. She's an orthopod, but I don't know that she's doing any global health work, but I think she is interested in doing it. So I'll ask about that from her to see if she has anything to say
Thank
about
you.
it. But that's the way I think about it is like you can go, you can have your short defined period of time, have a huge, huge impact for those families, but then you can also do something more longitudinal, and that would be more along the lines of education.
That sounds like I've seen the first option that you've mentioned. Some of my mentors they do that. They go to Ethiopia actually. Like my mentor, she is half Ethiopian and she goes back there every year. So
Oh, wow.
that I've seen. She's a hand surgeon. That I've seen. But the other aspect of it, which I also like, which I haven't seen just yet, but that's like really nice to know because I also like education. So I think like
Mhm.
that's another way that's kind of like maybe more sustainable
Yeah.
and not like these kind of short, tiny trips. But yeah, thank you
Yeah,
so
and
much.
it also doesn't require you to be in country. So if you have a crazy OR schedule,
Yeah,
but you
yeah,
have Fridays off and Friday mornings is your dedicated time to teach in Haiti, then you get to do that.
yeah,
You have your 1 hour, 2 hour lecture time with residents or with other orthopedic doctors who are in country. You can even do things where folks can present a case
mhm,
for, from either side and talk about how you would manage it. So there's lots of things that you can do and you don't have to leave.
yeah. Thank you so much. It was
You're
such a
welcome.
great talk. Thank you so much.
Great. One thing that I should have mentioned this earlier, but and maybe this could be a whole other talk, is just being who I am and being my chocolatey brown self, being a person in global health and how that's perceived. And I'm sorry I didn't talk about it earlier, but I was just thinking about it. That was something that was very interesting as well, because everyone has their predefined illusion of what an American is. And before leaving the US, nobody could tell me that I wasn't Jamaican and Haitian. Like, even in the US, they're like, oh, but you were born in Boston. I'm like, yeah, I'm Jamaican and Haitian, whatever. Because that's the way I grew up. But as soon as I got to Ethiopia and people were so confused that I was American because I didn't fit the American look, I kept saying it more and more. I'm like, I am an American. I was born on US soil. So I think that is something that a lot of people don't necessarily have to think about, but it's something that I am very aware of. Even within the larger global health networks now, there's this whole movement of decolonizing global health and how do we get global health to look more like the folks that global health is serving, right? So it's just something to keep in mind as you're going along, but it's something I never thought about. And probably because a lot of the places I had gone to, you know, if I'm in Dominican Republic, people think I'm Dominican. If I'm in Ethiopia, for the most part, people think I'm Ethiopian. Even in Colombia, people thought I was just like Afro-Colombian. But, you know, showing up in a lot of different places, people are like, but you're American. So just something to keep in mind. It's not a negative. It's just something that I never really thought that I would be thinking about so much. So
At least you're a global citizen.
I am a global citizen. I'm not gonna lie. I'm trying to get a Jamaica passport and a Chilean passport. My husband's Chilean, so I'm trying to get those.
Wow, good for you. Very, very global. How did you get into your medical Spanish or colloquial Spanish while you were in Colombia and DR and so?
Yeah, so I actually started taking Spanish in the 7th grade. So by the time, and Spanish was, I was double majoring in undergrad, and Spanish was my second major, but then I couldn't do any more courses. It was taking too long. So I had it be my minor. So I took medical Spanish in college, but I mean, all along I was reading literature in Spanish. I can't even do that now, but literature in Spanish. And then once I was out in Dominican Republic, out in Cuba, Puerto Rico for other reasons, and then being immersed in Colombia every single day.
Yes.
It definitely made it better. Plus, living in Houston, Texas. I mean, Houston, Texas is no joke. Half the time, it didn't even matter where I was. I could be in the supermarket and people just start talking to you in Spanish. So there wasn't a day in Houston that I did not speak Spanish. And even now in Rhode Island, we have a large Dominican population. So I speak Spanish every day at work, but not to the same extent. Like I speak Spanish at home and I speak Spanish at in the hospital. But in Houston, getting gas, going to the gym every day. So it's been a large part of my life for decades now.
Yeah. Which country did you meet your husband?
I met him in Houston, so that's another good reason to like Houston. I met him in Houston. He was finishing up his PhD, and yeah, it's I'll tell you that story offline. You guys could know too, but it was like a whirlwind romance. We were married within 10